Okay. So on page 348, it talks about the clinical applications. Sorry about that. There we go. Yep. Maybe. Let me do this until I fix that. I try me. Okay, so it says here, 348, the interest in using NMES or neuromuscular E-stim to increase muscle strength was initially sparked by Russian athletes observed being treated with it during the 1976 Olympics. So 1976 Olympics, we were all there, and the athletes were being treated with this E-stim, these big E-stim devices, and everyone wanted to know what were they doing, and why were they so much stronger and more resilient. The truth was they were using steroids, but they blamed it on the E-stim. So I don't want you to think I use E-stim and I'm going to get really huge, yeah, man, I'm jacked. Doesn't work that way. But steroids will. So, but don't take steroids. So in '77, a union of Soviet Socialist Republics, USSR physicians named Dr. Kotz gave a series of lectures in Canada and made claims that E-stim with a Russian-based current. So he named it Russian current. So he was using an AC-based current that was really specific. So it was different than IFC, but it was still AC waveformed. And he called it a Russian current protocol could lead to 10 to 30% increases in muscle strength above what an athlete could achieve through conventional exercise. The Russian current, he described, has been investigated with some mixed results. However, his claim did lead to renewed interest in using other more familiar NMES devices and protocols. Conventional exercise programs to increase strength are based on overload principle of eliciting a small number of high intensity contractions. So overload principle uses, so we use overload concept along with a SAID principle. So we use overload with what we call the SAID principle, S-A-I-D, specific adaptation to impose demands. So so when you go to the gym, what you'll do is you use primarily what's called overload principle. So where you're going to put enough weight on the bar, you're going to use enough weight where you're getting adequate resistance that you can move for a period of time so that you can build muscle strength. You know, you wouldn't want to go to the gym and you can bench press 200 pounds and you put a barbell with 2 5s on the end and just sit there and lift. You're not overloading the muscle. You're underloading it at that point. So you want to give it some resistance for challenge. Okay? So overload principle, again, uses we'll probably use like a 70% of the 1 rep max, and then we'll take that number and perform 3 repetitions of 10. So you do a 1 rep max, and then you're going to use 70% of that, and that's a good starting workout. The same parameters apply when using NMES to augment strength in healthy and healthy but injured patient populations. There is research that suggests NMES adds to strength gains that normal individuals can achieve through conventional training. However, in an intervention following limited traumatic or orthopedic injuries, NMES has been shown to lead to greater strength gains than those achieved with conventional exercise. So what does all that mean? The use of NMES in conjunction with exercise has been shown to enhance strength for injured people faster than just exercises alone. Because what we're doing with NMES, or with E-stim in general, specifically NMES, we're depolarizing the motor nerve, which enhances motor unit recruitment. So we're getting more fibers to fire. And that's going to improve strength quicker. When you have more, that would be like if we wanted to lift this table in the back, the treatment table. If I went to try to lift it by myself, there's only so much I can do. If all of us got hands on it together and tried to lift it, it'll be much easier. The more motor fibers you can recruit, the easier it's going to be to move a muscle against resistance. E-stim helps to recruit more motor fibers. So that's what makes it functional. Okay? So it says candidates for NMES can be any patient with multiple areas of weakness and deconditioning. These patients frequently benefit from a program that emphasizes endurance of a muscle. This emphasis on endurance spotlights other major functions of a muscle, the abilities to produce force repetitively. Okay. Yeah, we won't go into that side of it. Mm-hmm. Yeah. So yeah, that's exactly what they're selling you. All of the belts, they're not as popular as they were about 5 years ago. 5 years ago, they were selling them everywhere. All of the ab belts, ab belt 5,000. Trust me, use it, and you will have abs in a month. No, doesn't work that way. Yeah. Yeah, these things. All of these belts are things that they put on. And so all these are E-stim devices. They're what we call wearable E-stim devices. So you're able to put them on and wear them, and they were called toning belts. So they were waist trainers with E-stim mixed in. The only issue is, while they will fire the muscle, they're not going to make the muscle substantially stronger, and being able to see the abdominal muscles is not a function of having strong abs. It's a function of low body fat. So all the studies will show, if you want to have visible abs, you need to be somewhere between 9% body fat, no more than about 12. Anything more than that, you're probably not going to have visible abdominal musculature. So, but they don't publish those studies because those don't sell anything. So that's the truth. So COTS came up with Russian E-stim or Russian current, which is a Russian which is a AC type of AC current. Hang on, I thought I had it in here. Guess I don't. Okay. I do not. Okay. I thought I had it in here somewhere. It may be on another thing. How you know? Yeah. Yeah, that's it. So, yeah, this is the one I'm thinking about. So, what Russian current is, again, is developed by Dr. Kotz and some Russian-based scientists from 1976. It is an AC-based waveform. It uses, it's AC, so it uses high frequency as well, not as high as IFC, so it uses about 2,500 hertz versus the 4,000 with IFC, and it delivers it in bursts. So it has that overall frequency, and then it delivers bursts in packets of frequency even with that. So it has a continuous 2,500 hertz to break down skin impedance, and then what we will sense underneath all of that is the bursts that are released from it. Bursts are going to be delivered in 10 millisecond bursts, interrupted by about 10 milliseconds off time, which cannot be perceived by the patient. It all feels like one continuous thing. We'll get up to about 50 bursts per second. There are variations to Russian current that's already out there on the market. One is called Aussie current, which uses 1,000 hertz frequency, 1,000 hertz AC frequency versus the 2,500. So, shoot, how am I, there we go. How do I get that off? Here we go, okay. Yeah. Yes. So that's what happens with Russian current. It delivers a consistent 2,500 hertz frequency that's going to break down skin impedance, and then it starts to deliver the current that we feel that's going to depolarize the motor nerve in packets of bursts, up to like 50 bursts per second. And so we'll eventually use Russian a little bit later. Okay, so let's head, I tell you what, let's do some fun stuff. One of the things that Russian primarily works on is the use of motor points. So what I would encourage you to do is to print out the motor point chart. It should be listed on your Canvas accounts. So print out the motor point chart. We're going to kind of go through some of these today and have some fun. The first thing we're going to try to do is stimulate wrist extension, but we want pure wrist extension. So we're going to try to get, you're going to work with someone. You're going to place the electrodes and you're going to try to get pure wrist extension. When we're using NMES, again, it is important how we set this up, and you'll be able to see a difference. We're going to do the setup like we did yesterday, which is we had the cathode over the motor point and the anode either distal or proximal to the muscle. We'll do that, check the motion, and then we'll unplug it and do it the opposite way and see if we still get the same output. Studies show that the output sometimes is different, so we'll see. So partner up with someone, grab one of the machines, and we're going to do wrist extension. So you're going to be extenders of the wrist today. Okay. So some of you have already started to think and ask the very relevant question, how can we use this? What is this NMES thing for? What is it used for? So that's great. That means your brains are already heading in the right direction. You're already seeing, we talk a lot about contraindications, meaning things I can't use this for, but you're thinking in a greater term of indications. What is this useful for? What all can I do with this? So I'm glad you asked. So there are a number of different things you can use NMES for. It's actually a really functional, I wouldn't even call it it's a functional treatment technique for a number of different things. One of the main ones that we will use it for will be, some books call it muscle strengthening. We call it more muscle re-education. So usually post-surgical, or even someone who has had some type of deficit of strength and we need to do re-education, or we need to increase the overall strength that was produced by muscle. And so muscle strengthening or muscle re-ed occurs through two mechanisms. One, we can increase muscle mass, like if we're going to lift weights. So when you go to lift weights, over time you increase muscle mass. So that's hypertrophy through resistance. So we can get hypertrophy through resistance. SAID principle, specific adaptation to imposed demands. So I get hypertrophy or muscle strengthening through increasing mass. Or the other way that I increase my strength or I re-educate a muscle is that I improve motor unit recruitment. This is the big one, because this one does not require tons of weight lifting. It requires trying to cause a synergy to re-emerge amongst the brain and the muscle and the motor units that are responsible for the muscle fibers. So information comes from your brain in a motor tract to the spinal cord. Spinal cord carries it to a peripheral nerve. The peripheral nerve takes it to the neuromuscular junction, and that's where it's going to then begin to stimulate motor units that house motor nerves. So let me write all of this out again. So motor information, how is it transmitted? So information leaves So let's see here. Let's do it. So motor information. One, info leaves the brain. In a motor tract going to spinal cord. So information leaves the brain in a motor tract, just like we have the somatosensory tract carrying information up to the brain. We have a motor tract carrying information from the brain back down. So it gets there. Once it gets to the spinal cord then transmits info to a motor nerve. And the motor nerves are the peripheral named nerves that you know. Musculocutaneous, median, ulnar, radial, femoral, sciatic, common perineal, deep perineal. Those are those. Then step 3, it leads from the motor nerve to neuromuscular junction. So we're now getting it out to the actual muscle itself. So we've left the brain, we've left the spinal cord, we're moving away from the peripheral nerve or the motor nerve. Now we're at the actual muscle, neuromuscular junction. From there, the information is transmitted. Okay. Transmitted to motor units that house motor fibers, or not motor units that house muscle fibers. So all of my muscle fibers are housed inside of motor units. So if I wanted to increase strength, well, let's say this. Let's go this way. Majority of the problems with muscle weakness, specifically after an injury or after some type of deficit, is there is poor recruitment of motor units and muscle fiber recruitment. So we lose the abilities to recruit all of the motor units in a muscle once we either have an injury or some kind of deficit. We can't recruit all of the motor units on our own. So since the brain can't force this recruitment, E-stim comes along and it, through its depolarization techniques, causes for more motor units to respond than they would if we were doing it naturally. The more motor units that respond, the stronger the function is that I'm trying to produce, or stronger the motion that I'm going to produce. So if I am using NMES My goals are just like the ones listed at the bottom. I'm trying to increase the motor units being recruited. I'm trying to increase the frequency, how often they're recruited. And then I'm trying to improve the synchrony of recruitment. I want them all to fire at the right appropriate timing. So that is one use that we have for NMES protocol for E-stim. Muscle strengthening, muscle re-education. Another one is we can actually use NMES to cause for us to actually have range of motion produced. So if I have limited range of motion, I can use NMES to either stimulate the agonist muscle to try to get more motion, or I can stimulate the antagonist and cause it to relax, and that gives me more motion. So let's make that make sense. So let's say I am stuck in this elbow flexion, I won't call it a contraction. I'm stuck in this elbow flexion motion. I cannot move my arm into elbow extension. I can use E-stim to stimulate my triceps, which will then force them to relax and allow for more, and it helps with, I can stimulate my triceps, and that will help to encourage elbow extension, strengthening my triceps or recruiting more motor units. Or I can stimulate my bicep, the antagonist, cause it to relax, and that will let my arm have more motion too. So I can do one or the other. I can either stimulate the agonist, which is weak, to increase range of motion, or I can stimulate the antagonist, which is tight, to force it to release to increase motion. So I can do range of motion stuff with neuromuscular E-stim. We're gonna practice all of these today, so don't worry. I can use NMES to do edema reduction by doing muscle pumping, where I am moving my joint through a range of motion through E-stim's help. So even if I don't have the motor strength to do it, I can use E-stim to cause the motion to occur. Well, I mean, you can use it with lymphedema. People don't use it as much with lymphedema, but you could. Because you're trying to increase the flow of the lymph back into the lymphatic vessels. And active range of motion is a good way of doing it. So it could be used. Or I can use it for an orthotic substitution, where I have a weakness or a lack of muscle activation, but I still have an intact peripheral nerve. I can stimulate the area and it can serve as an orthotic substitution. Or it can serve as a substitute for bracing. That's actually the one we're getting ready to head to next. Okay. Okay. So the thing we're getting ready to do now, any questions about that? I forgot to ask that question. Any questions about anything we just mentioned? Yeah, so that's the FES part.
But it's still the same thing.
Hmm. So this description is more FES description than just NMES. Hmm. Okay. Any other questions? Okay. So, flip your books to page 367. This will be our lab activity. This should almost probably take us to lunch. So this will be an orthotic substitution type of situation, or a bracing substitution. So if I don't want to put a patient in a brace for prolonged periods, then I can use this technique to help them. So we're going to be doing E-stim for the treatment of what we call neurogenic shoulder. Neurogenic shoulder. Neurogenic. Neurogenic shoulder. So the book is wrong about one thing there. I definitely want to correct it before you read it and you start to memorize it. So it says here in the book, under where it says number 1, you're going to be doing E-stim to posterior deltoid, not middle, and supraspinatus. So the two muscles that are responsible for helping to bring the shoulder back up into its normal seated place and not be subluxed are your posterior deltoid and supraspinatus. So I will show you a picture of neurogenic shoulder, and you'll see this on patients post-stroke a lot of time. So it's a type of sublux shoulder. Maybe they stop calling that. Yeah, so that's a good picture. So that's what's happening here. So this is the acromion. So you'll be able to feel underneath so if you go out to the distal end of your acromion, palpate right off the edge, it should run you into the head of the humerus. In this condition, there's going to be a space in between where the head of the humerus starts in the distal end of the acromion. So you'll see here, this patient here has a 2-finger width breadth of space in between the distal end of the acromion and the head of the humerus. So this is where the head of their humerus is right here. That's the distance between that and the 2 fingers. So if we have this going on, if we have this problem going on, then we want to stem supraspinatus and posterior deltoid to help us draw the shoulder back into its normal place. So this one is going to be facilitation of the actual movement. So this is going to, so I want to see the shoulder pull back and go up, or see the shoulder pull into a little bit of extension and a little bit of abduction. So you're going to stimulate it to help substitute for muscle inactivity. So we could put them in an arm sling, but we want the muscles to start reacting. Okay? So partner up with someone. You'll use one of the portable stim devices that you're already using. You're going to put your electrodes over, you're going to need 2 channels. You're going to have them over posterior deltoid and supraspinatus. So that's supraspinatus. So there's supraspinatus. And this is going to be posterior deltoid. You can, so there are a couple of different setups you can do. You can use one channel and just hit motor points of both, or you can use 2 channels and surround the motor point and the actual muscle belly. So supraspinatus, its origin is back here, supraspinous fossa. So you can have one here, proximal to the sternoclavicular joint, and then one out distal over the muscle, over the motor nerve, or the motor point here. So we can have one here, here, and then posterior deltoid here, down near the insertion. Oh yeah. Cathode still goes over the motor point. Mm-hmm. Okay, so we had some really good questions, a lot of really good questions while I was walking around. One I wrote on the board, but I'll give you all a chance. Well, let's just talk about it in general. So, neuromuscular, well, that's kind of more along the lines of functional electrical stim. That would be FES for bracing. So we're trying to force the muscles that support the shoulder joint to contract and hold the shoulder against the acromion, the distal end, so that you're substituting for a brace. So I'm trying to substitute for a brace. So that's more along the lines of FES. We'll show you another one this afternoon as well. But what are your thoughts? What, anybody, somebody, everybody? It is a strong current, a strong waveform to do it. I agree. I agree. Anybody else? What'd you think? Strange? Okay. It's a lot of stim. Yeah. So it will make you fatigue. Now, which a couple of groups did. Who did the monopolar setup? Okay. Did monopolar, bipolar. I think you all did monopolar. Yeah. So there are a couple of ways you could have set it up depending on how you wanted to do it. If you wanted to do a monopolar setup, monopolar, so what would that look like? So if I just wanted to use one channel, so monopolar setup, it would be one channel, and you would have your electrodes over the motor points of both muscles. So wherever those motor points are off of that chart, that's where you have it. And you primarily want your cathode over the muscle you want to stim the most. Because it's going to produce more motion coming from the cathode. So that's monopolar. Good for smaller muscles, upper extremity stuff. I would not recommend it for lower extremity because it'll get really bitey. Well, you could probably with the big electrode, it may be okay. We'll try it after lunch. Then the bipolar setup would use two channels, and then you have the electrodes of each channel. Over a motor point and the muscle belly of a muscle. Cathode still over the motor point. Okay. So both techniques worked. Every group was able to get the motion we were looking for. The bipolar setup gives us more options if you want to do that, but both work. Both really work. Okay. So it was asked, when do you know if I'm going to use fused tetany versus just tetany or twitch? Great question. With NMES, there are very few, if none, there are very few, if I would even venture to say, nothing that we use twitch for in NMES. So we don't want to twitch for anything. This isn't functional for a patient. So in STEM, we're either using tetany, where I'm getting a strong motor response like you did earlier, and I'm able to assist the E-stim device moving into different functional motions, or I do fused tetany for substitution, orthotic substitution, or bracing substitution. So most of the things we're going to do is going to use general tetany, which is a strong motor response, but it does not control the motion. It's not moving me. Okay. Any other questions? Right. So general tetany, so regular tetany is just a good strong motor response that does not control the motion.
So earlier we felt the strong sensation, but we were able to move. That's just regular technique.
That's it. Strong motor response. Yes, ma'am. Making sure. Okay. All righty. Any other questions about it so far? Okay. Good stuff. Good stuff. Good stuff. Okay. Mm-hmm. All righty.
These, meals can be used for,
Mm-hmm. Any chronic or acute. Absolutely. Okay. So what we'll probably do, give you a lunch break. Yeah, let's take about an hour, come back about 10 after 11. Yeah. And then, no, 10 after noon, sorry. And then we'll pick up from there. Let's do that.